Welcome to this episode of the Psychedelic Mom podcast. I'm your host, Michaela Carlin. If you haven't had a chance to subscribe to my YouTube channel, please do that and share this content so we can expand our audience and bring more psychedelic news to you and conversations. What's it like to be a psychedelic therapist working in a clinical trial? What's it like to hold space for these transformative experiences? Are you interested in being a psychedelic therapist? Or are you working in the underground and wondering whether the practices that you're using are as comprehensive as they could be? Or are you somebody interested in doing a psychedelic medicine, curious about whether you're right for a clinical trial? How much is there to actually know to be truly prepared to hold space for somebody experiencing a psychedelic like psilocybin, MDMA, ketamine, 5-MeO-DMT, LSD? What does it take? Oh my gosh, there's so much to consider. We hear these buzzwords like set and setting and dose and making sure that you have intake protocols. But what does it really, really look like to be holding space for such a wide variety of experiences? On one day, you could have somebody experiencing gods and goddesses and having a Kundalini awakening. The next day, you could have somebody experiencing child trauma that was forgotten and having these memories come up. And the next day, you might have somebody experiencing deep, deep grief, losses that have never been metabolized. Next, you might have somebody shaking and purging and not really understanding why. You might have somebody who has an experience of ecstasy, experiencing their true nature for their first time. You might have somebody who wants to move around and dance, or someone who's experiencing their fears amplified, or ancestral trauma that they didn't even know about. How do you ready for that? And how do you ethically, compassionately, unconditionally hold space for these kinds of profound experiences? Today, I invited on Bill Brennan, and Bill has a PhD. He's a clinical psychologist, a psychedelic researcher, educator, and an author in New York City who has 2 decades of interest and involvement in psychedelic therapy. He has played a major role across several psychedelic clinical trials, including lead trainer, core faculty, curriculum developer, clinical supervisor, and he's the lead author in more than 8 treatment manuals. He currently serves as a consultant to Cybin and Gilgamesh, 2 prominent psychedelic research companies where he's involved in the development and delivery of their psychedelic treatment approaches. And today, I invited Bill on to talk about EMBARK. He developed the EMBARK model of psychedelic therapy with Dr. Alexander Belser. Kind of a big fan of Dr. Belser. The 2 of them teamed up and authored a comprehensive guide to psychedelic treatment in the approach entitled EMBARK, Psychedelic Therapy for Depression, a New Approach to the Whole Person. So I invited Bill here today to talk about this comprehensive guide, which I've been looking at over the last few days. And I finished it yesterday, but what I'm realizing is it's not really a book that you finish. It's really a manual to hold on to and to reference. It's really a comprehensive guide on how to work therapeutically with psychedelics. And I was really surprised. I kept kind of thinking, though, what did they forget? What did they leave out? It's pretty comprehensive. So Bill and I speak today about what brought him to this space of psychedelic therapy. He was actually just coming back from an ayahuasca ceremony, and today was kind of his first day back to work. So we talked about his own integration. We talked about also the underground and the wealth of knowledge that the underground has, and how do we begin to incorporate the wisdom from down under, where earth medicines are being served, not in clinical trials, and the approaches that are being used there. EMBARK is an acronym based on the 6 clinical domains that they felt were lacking in some of the other clinical trial psychedelic treatment plans. So we're going to talk today about what those are, as well as their 4 care cornerstones that they've included in this model. Anybody that is doing any work around psychedelics and holding any space for any kind of medicine work, I highly recommend this book. It's probably one of the most comprehensive that I've seen. When I was going through the book, the other thing that really hit me was how much there actually is to think about, how much care therapists and facilitators need for themselves to be available so fully to their clients, the questions that need to be asked to make sure that this work is really right for the participant that wants to do this work, and also really readying them for the wide range of experiences that they could potentially have, good and bad. And, some people say there's no such thing as a bad trip, and that may be true, but there are experiences that can really set people back. And we need to really educate anybody who's considering doing a psychedelic for all the potentials that they are opening themselves up to. We need to make sure that they have support beyond the clinical trial. Or if you're a facilitator that is really in the model of 3 prep calls, the medicine journey, and 3 integration calls, I continue to really believe that that's the minimum of what is needed. To really do this work, you're going to really want to have many more integration calls after, and as many prep calls as you can possibly have. So I hope you enjoy this episode with Bill Brennan and you're experiencing something incredibly psychedelic today. Welcome to today's episode of the Psychedelic Mom podcast. I am here today with Bill Brennan. How are you doing today?
I'm doing really well so far. Thanks.
It's good to see you. Thanks for being here.
Yeah, thanks for having me.
Bill developed the EMBARK model of psychedelic therapy with Alexander Belser, which has been used on 4 clinical trials to date. He and Dr. Belser authored a comprehensive guide to psychedelic treatment. And basically what you were looking at were different types of therapeutic models and what they were missing. And I've gone through this book. It is so comprehensive. So anybody looking to do psychedelic therapy or is currently doing it, you've put some pieces together that have been maybe lacking in some other protocols or systems. First, let me just ask you, how did you get here in doing this work in general?
Yeah, I thank you for the thoughts on the book too, Michaela. That's really nice to hear. I've been interested in psychedelics, like you said, for over 2 decades, based on some of my early personal experiences, which were really healing. And I wanted to become a psychedelic researcher back then. I intended to go to medical school, but in my early clinical experience, I ran into some things about the way psychotherapy is done in our culture that felt really limited in their perspective, limited in their scope, limited in the kind of healing they can offer. So I left the field of psychotherapy for a little while, and I went to some other fields. I worked in neuroscience research. I worked in activism and organizing for a while. I played a lot of music and gradually found my way back to psychotherapy by way of some other more critical ideas, liberatory ideas about psychotherapy that made it more okay to be a psychotherapist. And then by way of those same things, I found my way back to psychedelics and psychedelic therapies. And I have a lot of hope about the way the field could develop. I think it's still early days. We don't really know how it's going to look, but I'm more and more seeing that there is a lot of opportunity for psychedelics to inform the ways that we hold healing in this culture. And I'm excited to play a role in that.
As you were just mentioning, you were a psychotherapist that left the field for a while, and then you've had your own experiences with psychedelics and have real hope for some of the ways that this area is going in psychotherapy with the use of psychedelics. What were your experiences that made you think maybe psychedelics could really enhance and support people who are on a healing journey?
My early experiences, I remember them as being moments where I got in touch with parts of me that were previously offline. As a teenager, I learned how to not feel my emotions. I really shunted away any kind of spiritual longings or spiritual inclinations in myself. And when I took psychedelics, all those things came rushing back, and it felt so good to be getting closer to wholeness again instead of moving away from it. And I think in the early phases, I took that in a direction that a lot of people take it in, which is like a almost messianic, everyone's got to take these substances, everyone's got to do these things, and the world will just fix itself. And I stayed there for a little while, but after the dust settled on that, I just realized that there's a lot of difficulty in accessing these parts of ourselves without some kind of support, without some kind of additional resourcing. And I think psychedelics contribute to a kind of inner resourcing that allows for them to come up.
And would you have considered yourself a psychonaut? Were you someone exploring multiple different types of psychedelics?
Psychedelics and beyond, yeah. When I first tried mushrooms, one of the first impulses that I had afterwards was, I want to try every single drug on airwood.org, just going down the list. And every day of the week was a different one, just exploring all the different things they could bring up. And yeah, they're really interesting, but I think the field has settled on the ones that it's settled on for a reason, like psilocybin, MDMA. Those are the ones that have really done the most in my healing process.
Why would you say we've settled on those, would you say, from your own personal experience?
That's a really good question. I mean, MDMA, even other drugs that might be called empathogens, they don't have the same ability to make challenging therapeutic processes accessible and feeling adequately supported and feeling like you can feel your own capacity for attending to some of the things that you haven't attended to before. I think it's really unique in that regard. And psilocybin too, there's something about psilocybin and psilocybin-like molecules that has internal capacity to guide someone towards meaningful things, psychologically meaningful things. A lot of personal narrative content comes up, as well as these other things like spiritual content or embodied content. It all feels like it's there with psilocybin.
It's wild, isn't it?
Yeah.
I mean, it's like, I don't know how many times I've thought or had someone say, like, how did it know to go right there?
Yeah. And it opens up this really interesting question about the idea of an inner healing intelligence, or like a intelligence of the plant or intelligence of the medicine that guides us towards the right things. And I do think that's a big open question that we do need to explore more empirically before we make it the foundation of therapeutic models. But I know there's something in that ballpark has happened for me and many others I've seen go through the process. Yeah. But I think refining that idea is important too.
How would you compare your experiences with psilocybin mushrooms and like your experience this weekend with ayahuasca?
So much of it is down to context, like it's hard. It's apples and oranges, because psilocybin mushrooms, in a healing context, I've only done with a guide or a therapist, whereas ayahuasca, I've only done in a shamanic context. Shamanic context, there's a really good article that just came out, Psychedelic Therapy as Form of Life, and it talks about all the different implicit assumptions and biases of both psychedelic therapies and shamanic approaches to psychedelics. And it compares and contrasts them. And yeah, in these different approaches, there are many different, like psychedelic therapy is supposedly more open-ended, and you're letting your internal process unfold unimpeded, whereas shamanic approaches, there's much more guidance. There's more of an emphasis on getting things out of you instead of welcoming and accepting things. It's really different. And I don't know how they fit together in my own healing process quite yet. Like they both play a role, and I can't really speak fully to how one works in some situations and the other works in other situations.
So EMBARK.
Yeah.
How would you describe it? How to guide for how to work with psychedelics therapeutically? And was it originally for the use for depression?
EMBARK was something that Alex Belser, who's a friend of mine for 20 plus years, he invited me into Cybin to develop a model that they could use in their clinical trials that would be transdiagnostic, meaning it could be used for a lot of different clinical indications, and trans drugs, so something that could be used with many different medicines, but something that really holds the full potential of psychedelics. And what we did was we looked at a lot of different approaches that were already out there, like MAPS approaches used by other psychedelic sponsors, approaches used in academic clinical trials. And we found, to our knowledge, to our perspective, we found what really worked well about them, what looked really good and therapeutically sound. And then we questioned some of the other parts, and we tried to see if there was something from model A that could inform the gaps in model B. So it's very much a synthetic or synthesized model that we hope brings together the best of many other models. If you're familiar with another model, you'll probably read the book and see a little piece of this one and a little piece of that one. So we're standing on the shoulders of everyone else in the field in the sense that we are grateful and indebted to all the work that's been done. It's what we hope. I think of the book as almost like a celebration of where we currently are in the field, taking the best ideas that are out there and putting them together. Not that there won't be better ideas in the future, but just right now, this feels like Alex and my best effort to bring all the good ideas together.
Well, let's talk about some of the gaps that you have filled with EMBARK. It's an acronym. And I imagine that those are some of the places that you felt maybe some of the other models weren't emphasizing in psychedelic therapy.
Sure. EMBARK, just to give you a sense of the structure, because the structure really speaks to that question. There are 6 clinical domains that make up the acronym EMBARK. And then on top of that, there are 4 ethical care cornerstones that make up the ethical foundation of the model. The domains, they are in order: existential-spiritual, mindfulness, body-aware, affective-cognitive, relational, and keeping momentum. Existential-spiritual, it speaks to the fact that these medicines can bring up a lot of experiences for people that they perceive as spiritual, or that they perceive as really tied into questions of ultimate meaning or some of these other existential issues like isolation or responsibility. And we wanted to leave a very prominent space in the model for holding all these things and holding the possibility of something sacred arising for people.
So let's just take that one for example.
Sure.
What would you want someone who was a facilitator in this space to know about some of those experiences so that they can hold all that might come up that is within the realm of existential experiences?
This kind of speaks to your previous question too. EMBARK wasn't originally created to work with depression specifically. EMBARK is kind of like a meta model or an architecture that can be applied to other indications. And in that sense too, EMBARK is like, we wanted something that was responsive to the skill sets that practitioners were bringing into their work. So each of those domains that I just named, if you have particular skills that fit there, you can bring those from your previous work. And if you don't have skills in one of those domains, that's maybe a growth area for you. And you can either just rely on the guidance that we give in each EMBARK manual that we've written, or you can develop it some other way. But we don't really give final word kind of advice in each domain. So if you're a chaplain who has lots of great experience and skill working with existential and spiritual stuff, then you can bring all those skills to bear. But if you're a psychotherapist who maybe, like my clinical training program didn't cover much about spirituality, unfortunately. So in that domain, if you're a therapist with similar backgrounds to me, the advice that I would give is to really just don't impose anything is rule number one. Like don't bring your own spirituality, don't bring your own ideas and questions and burden the participant with those. But
so
also
important.
Really important, like really deep ethical questions around that Joe Welker and others have written about in the field. Yeah, you want to stay out of the participant's way when they have something spiritual come up. You want to be supportive. You want to be non-judgmental. Even if something sounds like it's at odds with what you think God wants us to do or think or feel, don't impose that on someone. So a lot of knowing yourself as a spiritual person or a non-spiritual person and knowing what your biases are and knowing how to bracket them is really important. And also, there's a kind of generic, non-denominational holding of the sacred that I think could happen for even therapists who don't have any background in spirituality, just making sure that the space is one that's welcoming of something that is potentially deeply meaningful for someone. Not being interruptive, not being overly casual, not being profane in a lot of the subtle ways that can happen in a medical context.
So, as a supervisor, I just want to jump off right there for 1 second. As a supervisor that has witnessed some of these clinical trials, what have you seen?
There's a lot of people who do get in touch with their ancestors. They do have experiences of talking to what they perceive as someone important from their life who might have passed away. Some people feel the presence of the divine, whether it's God or just some other kind of entity. Some people don't do it. They don't have an experience that might be something we think of as traditionally spiritual, but it just feels like something in their life, like their family or their partner or their loved ones. They can see them in a very profoundly meaningful light. They can see their connection as something holy and something sacred. These are things that I've seen a lot of.
Mm-hmm.
And what I've seen facilitators and therapists do that really hold space for that well is not trying to mine those things immediately for how they can help the person struggle with their depression and recover from their depression, but just treating them like the sacred things that they are and just letting them be resources without having to aggressively fit them into a particular box that someone learned in grad school.
As a supervisor, did you see things that ended up informing you to things that needed to be in this program, like areas where a therapist might have done something that might not have been the most effective thing to do with the participant?
Yeah, I have seen on one end of the spectrum, there are the therapists who don't have much of a spiritual background. And then there are some people coming into these trials and into this work with a strong spiritual background. And I have seen people taking their strong backgrounds and imposing it inappropriately in sessions. That's something that's required some supervision. And it's almost like a type of cultural competence training and just acknowledging that people come from different backgrounds, their experiences lead them in different directions, and honoring that.
And so let's go down these acronym a little bit more. The body awareness.
Sure. That's a good one.
That's a really good one.
It's a good one. And it's also something else that we're not really, for those of us with clinical psychology backgrounds, we're not really trained on how to work with the body in the way that is maybe most helpful in psychedelic sessions. I think a lot of mainstream evidence-based therapies, they attend to the body, but they do so as a place for gathering information about what's going on psychologically, like noticing your anxiety in your body and then coming up with coping strategies that can help you contend with that. So the body is almost like a site of awareness and pathology and tamping down of those pathologies. But what we've seen participants in clinical trials do, and not just me seeing it, I've seen this in the literature on other clinical trials too, is that participants have these experiences in their body that they see as part of their healing. They might have some kind of, like there's one really great story from, I think, the Bogenschutz work at NYU, where someone was able to see the toll that their drinking, their alcoholism took on them. And they can see it in their body in a very physical, very somaticized way. And they're able to interact with it on that level instead of just reflecting about it. Or there's someone in one of the, I think the NYU psilocybin for cancer anxiety trials, where they saw their cancer in their body as like a black cloud, and they were able to forcibly reject it and say, get out. There's almost like a automatic shamanism that happens. I mean, the person didn't have any kind of training, but they were able to expel something from their body in a way that was healing.
Interesting.
So leaving room for this. And again, this is a place where therapists might come in with some kind of somatic training, and we want to give them guidelines if they are bringing in something like somatic experiencing or Hakomi, because I think the full spectrum of what they learn in those approaches might not be something you want to see in a mainstream medicalized approach, just because we have to hew close to what is evidence-based. But just having the ability to honor, respect, to acknowledge these kinds of somatic experiences, and maybe even give a little psychoeducation to the participant to help them feel like it's normal and not something that is pathological and something a doctor needs to shut down.
Right. Yeah, let's go there for a second, just for anybody that's listening who's had an experience or is considering it, educating someone on some of the things that might come up. There was an article this week about yawning on magic mushrooms.
Yeah.
You see people burping, shaking. If someone was in the midst of shaking and asked, why am I shaking? What would you say would be a appropriate response as a guide or facilitator? Would you prepare them for that before they even come in? The potentials of some of the body things that might happen to you.
I think what you just said is really important. Like preparing them ahead of time is something I would definitely do. Because I think during the session itself, if you've prepared them insofar as you've told them that this might come up and it might be something they want to lean into, you can check to see if that's something they want to do. I would never force them to do that or just say, no, this is good, go into it, and just leave them there. But asking them first to see, is this tolerable? Is this something that you feel like you can try leaning into? And some people might say, yeah, let me try that. And maybe that's something that could open up something else for them. But others might say like, no, it's been going on for 20 minutes and I really don't like it. It's really uncomfortable. And then you can trust that knowledge and trust that wisdom. And you can guide them to a breathing practice or some other kind of grounding practice that helps them shift away from that shaking. Because I think we have to be humble too. I know I don't have the hard data that really proves that these things are healing. So I think when I'm working with someone, I have some humility around that. I say some people in preparation, I say some people have found this to be part of their healing, but we'll see how it is for you if it comes up. And if they don't like it, then we don't have to encourage it. And then during integration too, I just want to put in a word for post-dosing support. If they're still feeling something in their body that's unpleasant, like I've seen people have tremors that go on for days or weeks afterwards. And that's the kind of thing where if the person's really feeling that it's disruptive, not just saying, stay with it, it'll go away, maybe your next session will take care of it. Reminding them of their agency and saying, if you want to see a neurologist or a doctor, then that's something you can do. And maybe there's something they can do to help you. Just respecting people's choice around it.
Speaking of that, you just mentioned someone who's had a journey and has some negative effect or might be taken as a negative effect by a participant who is going in for psychedelic therapy and doesn't realize that for 2 weeks they might be shaking or some potential other negative effects. How do we as practitioners, facilitators, in your clinical trials anyway, how do the therapists prepare for all the potentials that could happen?
Yeah, great question.
How do you prepare a participant for the potential? We started with the existential. A lot of times that can be beautiful. It can also be a little scary. But also, what could be some after effects of the psychedelics?
Yeah, the list of after effects is huge. There's a list in the book, the EMBARK book, but it's probably not comprehensive by now. I hear new stories and they bring on new different kinds of phenomena. So it's a developing area and it's a really important one. And there's this
really
idea
important.
of,
I kind of paused on that, was like, whoa, like, wow.
And how do you have all these conversations about all these different things in 3 preparation sessions? I hope that as the field goes forward, we get wise enough to have more than 3 or more than 2 or 1 preparation sessions. Because I know in the underground, I know practitioners who've been working for years and they started doing the 3 prep model. And now most of them are up to 6 or 8 prep sessions, the responsible ones, because they really want to make sure that the person knows what might be in store. And they want to make sure that they have their buy-in, and they want to make sure they're also talking it through so that it's not showing up just as unprocessed fear during the journey too. So it's not just giving them the list and saying, you good, but really talking it through.
And also you just mentioned kind of the code of ethics and being trauma informed and all of these things as part of the EMBARK program. Can you talk a little bit about that? Because I think those pieces are really important when it comes to psychedelic therapy.
I agree. Yeah, they're very important. The cornerstones are mainly a response to a lot of the trainings that I've had as a practitioner. I feel like they're missing pieces in many, if not most, of the approaches out there. And the 4 cornerstones, just to name them, are trauma-informed care, culturally competent care, ethically rigorous care, which talks about relational harm and how to prevent that, and then collective care, which is keeping your eyes on the broader picture of the person's suffering. They're not just suffering in a vacuum, they're suffering in a social and political context, and that's part of what we have to attend to as healers. Trauma-informed care, I think is crucial because even people coming in with diagnoses that aren't trauma-related disorders, they might have a history of either things that we typically think of as trauma, like things that would help someone meet the criteria for PTSD, or something like developmental trauma or adverse life events that could show up in a way that doesn't fully get metabolized during a session, as we saw with some MAPS participants in the MDMA for PTSD trial. And we really want to attend to how that shows up in treatments, have aftercare options ready, not encourage the participant to bite off more than they can chew, have lots of grounding and resourcing options available for the participant during all phases of treatment. And we want to not encourage a kind of aggressive cowboy approach to diving into one's trauma, like really bite-sizing it, taking it at the pace of the human psyche instead of trying to get it all up and out in one shot. And then there's some more subtle things too. Trauma disrupts our ability to be in relationship in a lot of different ways, a lot of varied ways. And being able to go into a therapeutic relationship with psychedelics, knowing that and attending to that, and realizing that there might be a very strong attachment that occurs during a dosing session, and making sure, number one, you're not encouraging an excess of attachment by having the person rely on you too heavily for their well-being, for their autonomy, for their grounding, and then also making sure that they have other people in their lives who can support them and they're not just completely depending on you, and then working through whatever attachment or feelings of abandonment are coming up and not just cutting the person off after 3 integration sessions, and really making sure they're not feeling harmed by the treatment before they leave. Culturally competent care. Do you want me to go on to other ones too?
Sure.
Cool. Culturally competent care is something that thankfully I think the field of psychotherapy is attending to more and more, but I think there are things that are specific to psychedelics in there too. Just acknowledging all the different things about psychedelic treatments that can be impacted by someone's social location, like their culture, their ethnicity, their race, their gender, their sexual orientation, their income levels, their education, their immigration status. And yeah, it can impact someone's relationship to their emotions, their relationship to you as the practitioner, to what other treatment options they might have access to or want to have access to. And taking all that into account every step of the way is important. Ethically rigorous care, we know there are lots of boundary violations in psychedelic work, above ground and below ground. And they range from full-on abuse to things that are more just like smaller abuses of power, like misuses of role power, we call them. So not being a guru, not getting your own needs met to an excess by participants. We try to have suggestions for how to do all that really suffused throughout all of EMBARK. Collective care is something that's a little bit more experimental. I think it's further afield, but I think it's really exciting too. It's acknowledging that if we really want our participants to thrive and if we really want them to heal, we have to attend to the bigger picture of the things around them, structural oppressions, structural inequalities, opportunities that may or may not be there, and taking that into account when we're developing integration goals with the person. And also, if we really want to support people, just having our own practices for affecting that social context and that political context. What are we doing to lighten the burden on the people that we're trying to help?
Wow.
It's
amazing.
A lot. Yeah.
It's a lot. I mean, I was going through the book too, and I was thinking you've really addressed everything from the calls before, how to even structure them, and some of the things that you might want to contact on those calls, to dosing, to set and setting, to music. It's interesting. One of the things I stopped on when I was reading the music thing, I remember having an experience, and the philosophy of the person who was doing the music was like, that was the music. That was it. And at one point I didn't really like the music, but it was kind of like, well, that's the music. And I mean, it kind of was an exploratory process for me too, because I was like, why don't I like the music? And then I realized I was the music. I had some things to change. Like, it ended up being an interesting perspective. I liked the approach that you gave, even to music. Like, it's not a black and white. You can change the music. You can ask different questions to someone who's having the experience that might want the music off. It shows such a depth of attention to like the little details that are happening live in these sessions and being witnessed live in these sessions to make sure that you're including them.
Oh, thank you for that. Yeah, the
Yeah.
details, it grew out of the fact that I think this was for clinical trials where a lot of people were facilitators were doing it for the first time. So there was a lot of conversations, a lot of trainings where there were a lot of questions, and I would hear people's questions and I'd come back and say, oh, that should be in the book. There should be more detail on that. And music is such a huge thing, and changing the music is also like its own huge set of questions that I hope we get to at some point, because
Right?
some people changing the music, I think, might be changing it because it's making them feel something that would be helpful to feel.
Exactly.
But other people
Right?
changing the music just don't like the music and it's distracting them. So,
Exactly.
and what
And
are
I've had
we?
it both experiences
Yeah.
where it's either taking me into something and I'm like, oh boy, or the music is distracting and it's taking me away from where I feel that the medicine wants to take me for some reason. Yeah.
Yeah, there's no formula for it, unfortunately. And also, what are we telling the participant by saying, stay with the music you don't like? What are we communicating? Is it robbing them of some kind of agency or autonomy? And it's situation by situation, I think.
Really is. Each experience is so different. I mean, there's such a vast variety of things that you've probably witnessed as a supervisor. One of the things in the book, obviously, which is so important, is who is appropriate for psychedelic therapy and who isn't. A lot of times we'll say, like, well, psychedelics aren't for everybody. Well, who are they not for, and why, and what happens, and what has been seen to say, like, maybe that's not a good idea for you. And I think sometimes even, we talk about them as being amplifiers. Someone can come in and not even know maybe that they're an undiagnosed OCD, and it can amplify OCD in the session, perseverative behaviors and things like that. There's such a wide variety of things to really look at when it comes to, is this an appropriate therapy for somebody? How do you address that in EMBARK?
Ooh, yeah. It's another huge set of unanswered questions. The field is trying to move so fast, but we have all these really foundational questions to answer still. Chapter 4 has a lot of considerations around screening and appropriateness, but it's definitely just the tip of the iceberg. There's so much more to dive into. I think one thing that I've seen be really helpful in clinical trials with some of the people I've supervised is making sure that the person has other supports in their life, so that if they have an experience that's destabilizing, either in an adverse way or even in a positive way, like something really transformative happens, the people and the structures in their lives, are they going to be enough to hold that? Because the trial ends, the facilitator's only there once or twice a week for a session. So if we want to avoid the slippery slope of just giving the person like everyday care and encouraging this kind of dependency, there has to be something else they can rely on in their life. And I've seen some participants not have that, and it's really challenging to leave the trial and go back into it.
So there is so much positive news about psychedelics. I mean, psychedelics are being touted for healing treatment-resistant depression, anxiety, traumatic brain injury, beneficial for Alzheimer's and Parkinson's disease. What have you seen in the clinical trials that you have worked on that really excites you in this work?
I think what excites me is a little outside of the realm of what you were just naming, like reducing symptomatology. Yeah, and I think psychedelics can be symptom reducers, but what I've seen is people having these really meaningful experiences that might help them with their depression or might help them with their alcohol use disorder, but they're really providing resources for a more general kind of growth. Like they're getting in touch with themselves in new ways. They're opening up spiritual boxes that were in the attics of their minds. Things that they could be gifts to keep on giving. And a lot of times this doesn't map neatly onto something like treatment-resistant depression, but I think these are still growthful things and really helpful things. So I hope this is one of the places where I hope that psychedelics can transform mental health and psychiatry. I hope that we can start to see the transdiagnostic potential of psychedelics as evidence that there is some kind of broader set of resources within us that can be developed that are helpful around a lot of different diagnoses, like psychological flexibility, spirituality, embodiment, all these things that, are transdiagnostic.
Do you want to talk about when it went into the creation of it, how it's functioning as a model?
Yeah, the functioning as a model, I think the best feedback we've gotten so far, or at least the feedback that's felt the best, is that it's a very roomy model, very spacious.
Mm-hmm.
So for all these different participants having these different experiences, like you were just saying, it's been great for facilitators to have the room to think about things through this really broad 6-domain lens that EMBARK provides, instead of something like acceptance and commitment therapy often gets used with psychedelics, and it's great, but it is just like one lens. Psychological flexibility is the thing that people really tend to focus on there. So having this broader lens is, people find it helpful.
Mm-hmm. So you and I were talking a little bit before about the wealth of knowledge that the underground has.
Yeah.
And in a lot of ways, the underground in the United States has been around for decades, right? Even when MDMA was unclassified, people like Alexander Shulgin were giving it to friends and using them on them himself and using them therapeutically and studying them. And now there's a rebirth of the underground, not that it ever left. What's your feeling about the inclusion of some of that data from the underground in some of the information that's going into the clinical trials?
I think it has happened in a lot of ways, and it's starting to happen in new ways too. I think there's been a lot written about the revolving door between some corners of the underground and some of the folks working on clinical trials. And that's true and real. And a lot of the protocols that are being used in clinical trials, they owe a lot of debt to what's been done in the underground. And there are some studies that have been done, like one that I did for my dissertation, where the underground practitioners are being asked for their input in a kind of more formal way. I hope that there's more of that, first and foremost. I hope that there's more people asking underground practitioners for their input. Like Rachel Harris had this really great book about a year ago, Swimming in the Sacred, that I think is a huge resource for the field. My hope, though, is that when we do reach out to the underground, we try to do so in a way that's it's not so married to psychiatry and its own set of blinders. Because I have seen some people, research groups, going into the underground and asking questions in a way that's like, how many people with treatment-resistant depression have you treated? How many people with PTSD have you treated? And a lot of times underground practitioners are not working with diagnoses. They're working in this other place that's outside of the DSM. So we need to meet the underground on their own terms, while also being rigorous about how we collect information from them.
The clinical trials mostly that you've worked on, are they one participant in a room, not a couple or a group, small group or anything like that, right?
Yeah, so far I've just worked on individual therapies, which I'd love to, if anyone's listening who's working on a group trial, I'd love to get involved, because I think groups are the wave of the future. Like, it's going to make it more affordable. There's a certain magic in groups that can't really be replicated in individual settings.
No. I loved that you had in the book, too, the care for the practitioners. You might want to go for a walk or do a yoga class before your session, because you may be sitting in a static position for a while. Many aspects of doing the work on the psychotherapists and facilitators, physically, mentally, emotionally, the amount of self-care that's needed to continue to do the work from a place where you're not exhausted yourself.
Yeah, it's huge. It's really important. And one thing I unfortunately see in some of these clinical trials is that there's a lack of respect for that. We think the session is 4 or 5 hours or 6 hours, whatever it is. So that's less than one full workday. And therefore the facilitator can do at least 5 of these in a week. And I think that's so wrong-headed. And there are people in the field who are really arguing for, like we need to make this accessible, so we need to be able to do this on a more rapid clip. But if we're burning out practitioners, we're burning them out in a way that's going to ultimately harm patients too.
What are the challenges ahead for integrating psychedelic medicines in the current Western model?
Yeah, some of them we've spoken to, like
Yeah.
the fact that a significant percentage of participants are going to have experiences that need more follow-up care than we currently have built into protocols. Like there are people who I've seen people have experiences of depersonalization or derealization, and it's not appropriate to send them home. It's also not appropriate to send them to a psychiatric inpatient unit. So where do they go? I like to advocate for some new level of care that the field doesn't have yet, which is some kind of psychedelic containment center. It should be something that's funded by all the money that's going to be made on these treatments, because it's going to be a crucial part of this work as we start seeing thousands and thousands of patients. The other challenge too around acknowledging that maybe the experiences people have are not as tailored to symptom reduction as they are to some kind of broader sense of wellness and growth and healing and resourcing.
A different lens. It is less looking at, well, that we're dealing with anxiety or treatment-resistant depression. It's this person is suffering. We don't fully know why. Maybe the psychedelic will reveal something to us. Maybe this person can feel their highest nature, have some existential spiritual experience, feel a sense of their body for their first time, recover a memory that's actually maybe at the core root of the depression. And I know that's exactly what's happening in the clinical trials. Maybe just the languaging is different in the underground. I'm not sure.
The language is different, and I think sometimes that it's the same experience and the different language doesn't matter that much. But other times I feel like the language matters. If we evaluate psychedelics by way of their ability to reduce depressive symptoms, then they're going to, by many psychiatrists and mental health providers, they're going to be seen as in the same drug class as antidepressants. Like if someone doesn't respond well to Prozac, they don't respond well to Lexapro, they're going to be prescribed psilocybin, and maybe they're not appropriate for it. Maybe because they have TRD, it still doesn't mean that that's what's best for them. So I think it's dangerous and a little misleading to start seeing psychedelics as antidepressants or anti-anxiety drugs.
In the book, you're really trying to take the whole person approach by adding these gaps that you feel have been missing in other therapeutic psychedelic models, the spiritual, the embodiment, the keeping the momentum going. Hypothetically, you're creating a retreat, and it is a psychedelic retreat. From your experience in clinical trials, but also you just came back from ayahuasca shamanic setting. I'm sure just in your dissertation, you learned a lot from the underground. What do you think is the best model for this work?
I love that question. I'm gonna take that with me today and sit with it. My immediate answer is maybe an unsatisfying one, which is just that there is no best model. It feels, because I know I've heard stories of people in clinical trials who the medical setting is really safety giving for them. Like they're like, I wouldn't have done this anywhere else. I wouldn't do this at a retreat. And then there are some people for whom the medical industrial complex is very safety removing. It's very unsafe. So they might feel more comfortable in a shamanic setting. So I think what we're going to need is a diversity of approaches, like a real plurality, a real open field with guidelines and boundaries and safeguards and supports, but definitely not just medicalization, although yes, medicalization.
And where do you see yourself going in this space from here?
I've been in the clinical research for a couple of years now, and I've seen such beautiful work happen there that if medicalization is the first thing that pulls out in front, like if that's the winning horse, I would feel comfortable working within medicalization. And I know there's a lot of privilege behind that, just as someone who feels comfortable trusting the medical establishment, as someone who fits into it because of my credentials and my social location. I guess I'm fortunate enough to have that option. And I think I will do that eventually when we get there.
And when you say that, are you talking about maybe being in the position where you are serving the medicine and
Yeah.
being the therapist in the space. And
Yeah, the two things or the three things I love doing the most in the field are being with patients with the medicine, supervising other clinicians, other practitioners, and writing. So some combination of that feels good to me. And then I also have this other piece too it's important to me because it's part of what, like I was saying before in my intro, it's part of what brought me back into the fold. These ideas of critical and liberatory psychotherapy that essentially they say that healing has to incorporate the context as well. I would love to continue working on that front. EMBARK is a good first step towards that, but it's really a small first step, this idea of collective care. But I think there's something that psychedelics do when people take them, either in medical settings or I think more often when they take them on their own. There is this messianic sense of like, this stuff could change the world. Everybody needs to take this. Like there's something in there that wants to be shared. It's not just individual healing that's happening. And I don't think it's as simple as what people's first impulse is. Like, I just want to turn on everybody else. I want to bring everyone to the medicine, because it's not for everyone, like you said. But I think that there is something in that impulse to really listen to, something about what it is to be shared, what it is that the collective can benefit from all these individual experiences.
yeah, it is interesting when you first are introduced to these medicines, that evangelical desire to just want everybody to have that experience of, I
Yeah.
guess, when suddenly you have this experience of aspects of yourself. Yes, it's so natural to just want other people to have access to that, or your true nature. The contact with your breath sometimes after medicine is like, wow, how have I been missing that? These subtle aspects of medicine, and even in, as you talked about, the smaller group, the connections that are made, and just being there for somebody who might be shaking or who's having such a mystical, beautiful experience, not even to say anything, just to be present with another human being in their experiences. I think the connections between humans is something that we're not seeing as often as most of us would like, especially in our Western culture.
Yeah, and psychedelics, that's part of what I feel like they generally do is they push us towards other people. They push us towards other humans. And that's if we have a beautiful experience that we want other people to have and we want to share it with them. And it's also if we have a tough experience and we want support, it pushes us towards other people too.
Definitely.
Raz Watts has this idea of connection being the heart of what psychedelics bring to people. And I think there's a lot of truth in that. It's not just about the goodness of the experience too, because we can have some other pleasurable experience, like we could take a Percocet and we don't necessarily the next day want to go out and give it to people. It's something about psychedelics. I think it unveils some kind of human potential in us that we intuit in others, or we imagine in others, or project onto others, that we want to help unlock for them too.
Yeah. And I think that's a really important point too. It's not just the beautiful experiences. I mean, I think it's been my hardest experiences that in some ways are the catalysts to the most self-awareness and change, and they're just as beautiful. And even, as many people say, they build our capacity to be able to hold all of life, all the emotions that we experience in life a little bit more.
Yeah. Yeah, there's this beautiful metaphor. I'm not sure where it comes from, but if you were to take a shot glass full of water and squirt a half ounce of blue ink into the shot glass turns really blue. But if you were to take a bucket of water and squirt a half ounce of blue ink into the bucket, the water doesn't necessarily turns blue, the ink dissipates and it's barely noticeable. And I've had psychedelics described to me as turning our psyches from a shot glass to a bucket. And like you said, just increasing our capacity to hold all these facets of life.
So what will you do in the next couple of days for your integration for ayahuasca?
I think the main thing that came up for me, and I could be a very anxious person, and sometimes I deal with that anxiety by hunkering down and just like moving on to the next thing, and almost like like a little cannonball run through my day. But what I was learning on the ayahuasca, it was a very somatic experience. It was just a different way to relate to those feelings when they come up, those feelings of something's bad, something's wrong. And it's hard to put into words because it is so somatic, but just attending to them in a different way and just being with them differently than I normally would. And I think that's one of my favorite forms of integration, is just that somatic anchoring is what I've called it, where you can, if you notice some kind of shift in your body or your way of relating to your body, that's where the gold is at, because you can stoke that new capacity. You can build a bridge with that new capacity over the days and the week after the journey. And that can, if you build it right, that can last a lifetime.
I agree. I also liked the affective cognition. And is that really just beginning to expand and look at the way you think about things and be more flexible in the mind?
I would say the flexibility piece is more under mindfulness, the M domain.
Okay. Mindfulness. Yeah.
But yeah, it's a big piece there. Like being able to take a step back from your own mind and say, oh, here's what I'm doing. This is what's going on. This is what the mind is this is its habit pattern. Mm-hmm. And having more freedom of choice around how to respond to that.
I think even going back to what you were saying about the sensations in the body, that you can have these intense sensations in our body. And I remember after doing psychedelics for the first time thinking like, oh my God, psychedelics gave me anxiety. I mean, it didn't last long, but what I realized was, no, I've been shutting down my body for so long that I wasn't aware if something came up that was like a bubbling of something. And then the realization too, that a lot of times our sensations, we're labeling them. And the more we can just sit with like the sensation itself, they're not so bad. And so much of our lives, we're like running from these emotions or sensations that actually, when we slow down and just feel them, it's like, it's actually not so bad.
Yeah, that's one of the huge gifts of psychedelics, right? It's just being in touch with these things and feeling like we can hold them. I feel like there's always this iterative 3-step process in my healing. I take psychedelics, there's an increase in something coming up, and there's a simultaneous increase in the capacity to hold those things that come up. And then there's a greater sense of, well, I can do more in my life, like a greater sense of possibility. And then when I go out and do that, it starts the process over again, and there's more difficult stuff that gets churned up. And then there's more healing work that builds the capacity, and so on and so on. And this is one of those places too, where I hope we can figure out, because I think right now there is a tendency to say to patients, if they are feeling something like anxiety in their bodies after a journey, that is capacity building. And I think, in my experience, 4 times out of 5, it is, and it resolves, and it's okay. But how do we not gaslight the other 1 out of 5 participants? How do we know? Yeah, so that there's more work to be done there.
Definitely. Do you find even in those cases where there has been something after a journey where someone is struggling with something, that it's very stressful for the therapist, or no?
Yeah, there's a variety of ways I've seen people feel. I think I don't mean this to sound superlative, but I think the therapists who are maybe the most humble in their role are able to really let themselves feel genuinely worried about that. Like, I don't really know if this is going to resolve. I hope this turns out okay. I hope that I can help this participant find sufficient support in their world, but I don't really know how this is going to pan out. I've seen other practitioners who are more hard-headed just be like, oh, the medicine gives you the right thing, and this is part of your process. You'll grow from this even if it's 20 years from now, kind of thing. That's not my favorite.
Well, thank you so much for being here today. Is there anything else that you would want to share about EMBARK that you feel like we didn't get to today?
I realized this, I've done a couple other podcasts lately, and I realized at the end of all of them, I never said the title of the book, which you're supposed to say a lot. But it's EMBARK Psychedelic Therapy for Depression, a New Approach for the Whole Person. And if people want to check out the EMBARK Open Access Training Program, there's a couple of videos that were part of the EMBARK training for facilitators with Cybin and with the University of Washington who are EMBARK trained. And That is at embarkapproach.com. You can click on open access. It's completely free. You can register and watch the videos. There's one video on each domain, and then there's a video on each care cornerstone. And I think there's other videos on other topics in there too. Like there's an intro to Embark. I'm really happy with the way the book came out. We tried to make it comprehensive. Nothing's ever comprehensive. There's already paragraphs I'd love to rewrite, but I think it really is an encapsulation of many of the best practices that are out there in the field right now. So if you're interested in learning more about psychedelic therapy, it's a great deep dive.
I think it's great. I really do. I think it's really needed and very comprehensive. And as you said, yeah, of course, you'll want to add to it at some point, maybe.
Yeah, Alex and I are already talking about version 2, if there is a version 2, how we might shift some things and reword some things. So it's a never-ending process. But yeah, it's great the way it is too. We can hold both truths.
Yeah, exactly. Yeah. Exactly. Well, thank you so much.
Thanks, Michaela. Yeah, there's so many more things that I'd love to say about it, but they're all in the book. So let's just let the book speak for itself.